in terms of recurrence risk because anticoagulation has a 90% risk reduction as opposed to aspirin, which is very modest. So we have this conundrum where we have to decide what to do. And the last thing is really the future. As we know, we now have new oral anticoagulants on the scene. In the US, 3 of them are now approved for secondary prevention of VTE. I just showed you this data from the last of the agents to be approved in the United States for VTE treatment, secondary prevention. It's apixaban. And they did an extension study whereby they compared 5 milligrams twice a day versus 2.5, which is a prophylactic dose, if you will, versus placebo. And in terms of efficacy, the rates of efficacy were about the same between the 5 and the 2.5, but what's particularly striking is the bleed rate, that the bleed rates were really no different between, that's what you see here in terms of major clinically, they were no different than placebo in terms of the major bleed rates in this particular study. So the real question for the future is, I think, will the improved safety profiles of new oral anticoagulants lead to the extended or indefinite treatment of more patients with a first unprovoked VTE? Basically, greater net clinical benefit if you basically can do away with some of the bleeding complications that we know are associated with vitamin K antagonists to make this whole seesaw a little bit more favorable on that side. The last issue, of course, then, talking about the new agents, is how do they compare to vitamin K antagonists in patients with thrombophilia? We don't know. None of the patients in any of the studies were studied for thrombophilia, nor for hereditary or laboratory markers of APLS. I must say, I don't think there's any a priori reason mechanistically, in my view, that the new agents would not be effective and safe in patients with hereditary thrombophilia or uncomplicated patients with APLS. And I could even make a case that for antithrombin deficiency, it might be preferable to the heparins, or for protein C to warfarin. But I think you have to be cautious, particularly in people who are clinically difficult. And there's already case reports emerging about problematic patients with APLS and the new agents. So I'll stop there. I want to thank you very much for inviting me and allowing me to speak, and thank you all for coming.
Entonces, está abierto para preguntas y comentarios, tanto para el doctor Martínez Murillo como para el doctor Kenneth.
Una pregunta es, doctor, comentó el hecho de pacientes con trombofilia hereditaria, hay pros y contras. ¿Qué hacer, la pregunta en concreto para el doctor Kenneth Barro, qué hacer un paciente en un familiar que tiene deficiencia tiene mutación 5 Leiden y está embarazada? Hacer profilaxis en una paciente que nunca se ha trombosado, pero que es heterocigota para la mutación 5 Leiden, o simplemente observarla.
So the question is the asymptomatic woman who might be found by family studies because, let's say, one of their parents or a sibling has had a thrombosis and carries the mutation, and they are found to carry the mutation. I think most of those women probably can be followed expectantly without anticoagulation. If you look at the data out there about the risk, it seems to be very low. But again, I do take into account the family history. If it's only one individual who's had an event, it's different if you have many individuals in a very highly penetrant family, which is generally not the rule in the Leiden families, but occasionally you will see a more penetrant family. But I will generally not prophylax a Leiden patient antepartum, nor necessarily will I do it postpartum, but I will see the patients and advise them if they have other risk factors, if they undergo cesarean section, if they undergo bed rest for preeclampsia, that then they should require prophylaxis, or if they develop any kind of complications, I'll do that.
La experiencia que tiene él con el estudio de pacientes que tienen doble alteración de la frecuencia de enfermedades hereditarias, porque se reporta que a veces hay casos, una cierta proporción de pacientes que tienen dos enfermedades de trombofilia, y cuál sería el manejo en esos casos.
Do you have okay, the question is if those patients who have two abnormalities, which will be if there is one standard of treatment, they must be treated in a different way as a patient with a single thrombophilia abnormality. This is the question.
So I guess we're referring to people, in general who may have two hereditary thrombophilias. So we could be talking about somebody who's homozygous for factor V Leiden, or homozygous for thrombin mutation, or a compound heterozygote for both Leiden and prothrombin, or even occasionally you get people who have antithrombin and Leiden. I think some of these patients, particularly people who have antithrombin protein C, protein S, and another thrombophilia, tend to be pretty strongly prothrombotic. And even though I alluded to that one study where there may not be a higher risk of recurrence in homozygotes, I generally, if I'm going to study people and find people with two defects, I do respect that and tend to worry about those patients more in terms of thinking about longer-term therapy for those people, maybe indefinite therapy if they've had an unprovoked event. There are always issues about, is the standard management all right for those people? And I guess that's where the question, I have pretty full confidence in standard heparin, low-molecular weight heparin, warfarin for these patients. The real question is the new agent satisfactory for these more prothrombotic patients? And we don't really know the answer. It's going to take a fair amount of study to get these people and to study enough of them to know, because sometimes they present with much more severe thrombotic events with bigger clot burdens, so they tend to be higher risk patients when they present by virtue of their thrombophilia. But I don't have any priority. I really use how the patient presents as maybe the criteria whether I'd be comfortable using monotherapy with a new agent. I get particularly scared when somebody has a huge saddle pulmonary embolism and they're put on the new agents. I just recently had a woman who had massive pulmonary embolism. She was an older woman without thrombophilia, I believe, who almost died. And after a few days of heparin after thrombolysis, the cardiologists put her on rivaroxaban. She was doing all right, but she was a nurse. She was extremely anxious about no laboratory measurements and ultimately was switched back. I must say, for people with really big clot burdens who are difficult, I do feel more comfortable with monitored therapy, and that really the agent we know how to monitor is warfarin. I have a number of people with relatively severe thrombophilia in my practice, antithrombin, and I have no interest in these people have broken through warfarin. I think warfarin for them, if they can take warfarin and be monitored and be compliant, I think, frankly, I don't see any great impetus to change.
Cuando al paciente que presentaron, él tenía un árbol genealógico en el cual encontraron la mutación por el lado aparentemente de la mamá que había tenido la trombosis, pero del lado del papá también tenía algún antecedente de infarto joven, y yo no sé si hicieron más estudios para ver si se trata de un heterocigoto compuesto y podría tener un riesgo más alto de repetición de la trombosis.
Bueno, la presentación de este caso se nos hizo interesante, complejo. Evidentemente no se pudo hacer todo el estudio familiar, porque evidentemente, bueno, pues el doctor comentó la dificultad de que todos no estaban disponibles, y sabes lo que nos encontramos al estudio familiar. Evidentemente la posibilidad de que por ambos ramas, tanto por la carga genética materna como paterna, pues evidentemente parece sospechar que el paciente podía tener un doble heterocigoto.